Morning, everyone. If we could all find our seats, we're going to get the plenary kicked off here. So it is really a privilege and an honor to be able to introduce our three panelists for today's third plenary of the conference that is on charting the future of prevention D&I science. I had a cute little title about, smooth sailing or rough seas to try to be a little bit provocative, but cutesy titles don't always work. You may think, so I am the conference chair and was responsible or irresponsible for coming up with the themes for the conference this year. And it may seem at first glance that the charting the future is just because I couldn't actually think of a third topic. And so kind of deferred to the experts on what they wanted to do for what they thought the charting the future was about. But in fact, it was pretty intentional. This is the 30th anniversary of SPR. And as you know, anniversaries and other kinds of big milestones tend to generate a bit of reflection. And, just as D&I science and prevention science are sort of growing together, they have room to grow and lots of things that really could turn the tide potentially over the next 10 to 20 years in the science. So really was hoping to have a couple of these sessions that would help us, again, really chart an agenda and spur some thoughts about ongoing challenges, emerging challenges, and things that maybe we haven't even thought about yet that are going to challenge our ability to get preventive interventions into the real world. So I'm going to introduce all three speakers simultaneously in the order that they are presenting to kind of reduce the back and forth transitions here. So our first presenter is joining us on Zoom is Dr. Shiriki Kumanyika, who is a research professor of community health and prevention at the Drexel University Dornsife School of Public Health. She is also the founding chair of the Council on Black Health and holds a professor emeritus appointment of epidemiology at the University of Pennsylvania. Our second speaker is here in the room, is my colleague, Dr. David Wetter, who is a professor of population health sciences at the University of Utah School of Medicine and an investigator in the Huntsman Cancer Institute. Also directs the Center for Health Outcomes and Population Equity, or Center for HOPE. And our final presenter, who is also joining us remotely, is Dr. David Chambers, who's the Deputy Director for Implementation Science in the Office of the Director of the Division of Cancer Control and Population Sciences at the National Cancer Institute. David was also previously the chief of the Services Research and Clinical Epidemiology branch at NIMH. And at that time was a regular attendee here of SPR. So we're really glad to have David back today. So I'm going to go ahead and turn it over to Shiriki and enjoy.
Thank you. My video, the host has to let my video show if you want to see me. Otherwise, you'll have to see the picture. I'm still trying to get on camera. Okay, well, if that doesn't work, it says the host has stopped it. So I'll go ahead and start, and maybe I'll show up on camera soon. I think I have permission to share my slides, so let me try to do that. And can somebody let me know if you can see the slides? By voice, perhaps?
Yep, give it 1 second. We're switching over to you.
Okay.
Okay, now we can see them. You're good to go.
Okay, and you still can't see me, right? Just the photo. But...
Yep.
Okay, all righty. Well, I'm very pleased to be here virtually. I wish I could have come to Seattle, but that was not in my within my possibilities. But I am really delighted to share some thoughts. I hope there'll be something new to say at this point in the program, because I looked at the plenaries and I see that you've been discussing these equity issues for the entire conference. I'll preface my remarks by saying that although I'm pretty much engaged in increasingly engaged in implementation science with colleagues primarily at WashU, St. Louis, Ross Brownson, and training program that David is involved in. But I still consider myself an outsider to the field because I was not involved with it in the beginning, except the very early beginnings when translation was being talked about. And I look at implementation science primarily as a way to achieve equity or to foster equity. So this topic is very important to me. I think there are a lot of commonalities between implementation science and health equity science. And so I'm going to build on some work that I did with Ross and other colleagues at WashU to try to identify what we see as some of the challenges, and then I'll build on those to add a few things that you might not have discussed so far. I do see a lot of opportunities for leadership, and I took the cute title seriously, so I may be a little bit provocative, but hopefully we can discuss these things along the way. So this is the paper that I co-authored with Ross and Matt Kruder and Deborah Hare-Joshu. And in this paper, we tried to lay out these challenges and talk about some potential solutions, measurements, study designs, and so forth. But there's still a lot that needs to be done. And I see that the writing on this issue in the literature, papers that have cited this paper and others, is really growing. But I think we're not anywhere near addressing some of these challenges. So from a health equity perspective, there's a growing urgency to tackle issues of equity and social justice in the public health field and in the country. And we're prioritizing the equity language because it does introduce that idea of fairness and sort of a moral obligation, moving away from the deficit mindset of just what's wrong and more wrong with populations of color or socially disadvantaged populations. And one is pretty positive about what we can achieve as a society. I think the concept is not that well understood still and accepted. So we're still trying to explain the definitions of equity vary, what the goal is, and the evidence base is quite limited for advancing equity, as I'm imagining that you've been discussing over the past couple of days. And finally, the contributors to inequities may be seen as out of scope, not necessarily by the people attending this conference, but in general by researchers, people who consider themselves good researchers may feel that the messiness of some of the public health issues or the community context is really complicating scientific research on the efficacy of interventions, and is willing to bring it in on at a limited scope in terms of effectiveness, but not really embracing the contextual issues so much. The second slide here is taking the implementation science perspective. So what are some of the gaps that are related to equity? So first, how does equity, what are the issues in equity? And now what are the issues in IS? This is from our paper that it's still not mentioned enough, in implementation science, disparities or equity. It's present, but the broader vision for equity is not there yet. Perhaps will come out of this conference. It's not strongly featured in the funding announcements for implementation science. And there's really a lack of overall guidance on how to operationalize health equity in implementation science. The models are being expanded and enhanced to put equity considerations there. But again, I think we have a long way to go. I do think that implementation scientists can help to lead the field on this topic in various ways. So moving my slides here. Okay. So this is what I'm calling an even deeper challenge. And this is, if you remember nothing else, or we discuss nothing else, this is what I'd really like to discuss with you. This is from a recent report, Commonwealth Foundation, a Commonwealth Fund. It tracks the ranking of the US healthcare system against peer countries. And I put this up because I see the origins and embeddedness of implementation science in medical and healthcare models. I'm contrasting that with community health or public health models. The embeddedness there, which is in the language, in the standards of, is this really implementation science, the frameworks and stuff like that, it really is still very healthcare based. And I see that as not a fatal flaw, but something that we really need to address. So in this report, and which is one in a series, it's updated every few years, it points out that the US, if you can see it, I'll use my pointer in case you can see it, that the US is, we're an exceptional country, and this is a form of exceptionalism. We are ranking lower than our peer countries on the performance of the healthcare system. And what that means is that even if we use implementation science to perfect the process of healthcare, we may be very far away from really having an impact on the core equity issues. So if you look at the bottom of the screen and you see the rankings, I have to move the pictures here, see the rankings on the different criteria used in this report, you'll see that the US is ranking second out of these 11 on the healthcare process, but it's ranking 11 out of 11 on everything else, including the equity criteria. And so any index like this is going to be limited by what measures were used. In this in this international comparison in high-income countries, the metrics were related to income primarily. If you add things like racism, you would probably get an even lower ranking, I think, in this case. But look at our rankings. So what is the ultimate goal? What is the big picture that we're trying to change? Are we trying to tweak our healthcare system so that the process works a little better in socially disadvantaged populations? Or are we really trying to address equity issues, which would mean that we have to challenge the health system? We have to use implementation science to really challenge the whole way the health system is working. And maybe one of the outcomes we'll be looking at is the proof, quote unquote, that the health system doesn't work, because implementation science can't address, at least not for equity, can't address some of these issues. The other paper that I collaborated on with some of the WashU colleagues is a paper on expanding implementation research to prevent chronic diseases in community settings. And this, we had a hard time with the name of this paper because we didn't want to say non-health. We wanted to value these settings for what they are, which are community settings, provide many, many other things for people, have many resources, have more access to people than healthcare settings do. And so we tried to lay out what is known about implementation science in these settings and what the opportunities were. And again, so I think this is the second opportunity I'd like to present, also a challenge of bringing implementation science, evidence, and practice much more into the settings that can deliver health programs or health-oriented programs, but that is not their primary mission. And this is the final challenge I'd like to put up for discussion. We're talking a lot about social determinants of health at different levels. And from what I see, there's a lot of mixing of strategies that relate to social needs or individual or family needs and of different types, the community level social policies and resources, and the structural determinants, which include historical factors, structural racism, discrimination, national and state policies. And the reason I think that these need to be really separated and looked at for the different pathways that are involved is because the types of solutions that we need at these levels are really different. We have, for social needs, in a way, it looks like they might be the easiest for health systems to deal with, addressing food insecurity at the individual level or family level, maybe helping with some housing costs or other things. But those are the workaround or compensatory interventions that will never really address the fundamental causes. And I think we know that. So this is the immediate and acute, but it's not the long-term solution. The longer-term solutions are in communities and in the bigger picture structural determinants, and require a good understanding of history and the structures and policies that are perpetuating discrimination at the structural level. And those are policies, national policies that trickle down, and also state policies that affect what happens in localities. So my last slide is from an article that's available now in pre-pub on the annual review of nutrition. And this is my concept. It was obesity focused. And my concept here was implementation science. If you're looking at obesity equity issues, which are of high priority, can be the culmination of a process leading to health equity. The higher priority, adopting a health equity lens, strengthening the approaches by using the health equity frameworks that really help you to see which pathways are leading to what equity outcomes, and looking at a broad range of policies, not just the ones related to the outcome, but your specific outcome, but broader policies that may affect several outcomes at once. And when those things are addressed, then emphasizing implementation science concepts and tools to operationalize and implement the insights from these other processes. So I will turn this back over to JD and look forward to the discussion.
Note. So just one note, our presenters were given about 15 minutes each to do their presentations intentionally so that we have plenty of time for questions and discussion and dialogue from everyone in the audience. So if you've been sleeping, now pay attention. So you have two people to ask questions of.
It's weird looking at yourself really big. Are my slides going to come up automatically?
Yep.
Or okay?
You should be able to switch them over.
Great. Well, good morning. JD informed us about an hour ago that we were going to do the sandwich approach, and I thought, oh yeah, sure, where you do the good stuff, the positive stuff, then you deliver the bad news, the yucky stuff, then you end up positive again, and then he goes, Dave, you're going to go second. So I apparently am the yucky stuff. So let me start with some disclaimers. There we go. Disclosure, unfortunately, nobody gives me any money. Except unless I get a grant. So, and the disclaimer is that I'm a behavioral scientist. I do a lot of intensive longitudinal data collection, intervention development. I consider myself a translational scientist. I am not an implementation scientist, although I started working in that space probably about 15 years ago, frankly, because I got pissed off that all the stuff we were working on, nobody was going to get. So, even though I'm not an implementation scientist, I did stay in a Holiday Inn Express last night and I watch a lot of medical dramas. That's my entire knowledge of pop culture gleaned from watching ESPN while I work out. So what I thought, crap, if I'm supposed to do the future of implementation science, I'd better look and see what all the big names do. And then I thought, no, the thing I'm really, really good at is giving unsolicited, biased, non-objective opinions. And so I thought, and that plus it doesn't take me any work. So that's what I decided to do. And so you're going to hear just literally my observations of actually working in health equity for the last 25 years. And everything I'm going to talk about is about health equity. It's in the context of working with community settings, but it's all about health equity. So first, I'm going to just tell you briefly why we should even be focusing on health equity, talk a little bit about targeted approaches, social determinants of health, and then what I call doing hard things, which is really pulling together large groups of multi-sector partners to actually try to make a difference. And engagement, sharing, reach, designing for sustainability. And I know everybody and their dog is talking about that. Ours is maybe comes out from a different perspective slightly because I'm not an implementation scientist. And then I'm trained in clinical psychology, I'm a behavioral scientist, and the need for us to get to mechanisms, to really study with the same rigor that we do in individual level behavioral research mechanisms that are driving this work. And then lastly, about disseminating what we do. So why focus on health equity? There's a million great economic arguments. There's value in the healthcare system. It's not very complicated though. It's the right thing to do. It's something we should have been doing for a very, very long time. And now I'm going to talk about non-targeted approach or targeted approaches. Everything we create, whether it's new treatments, new drugs, new population health approaches, new public health approaches, exacerbates health inequities. Doesn't just have a sort of a mean effect. It actually exacerbates them unless we do something specific to reach out to underserved populations. I do a lot of my work in tobacco. We've been doing this for a very long time. Tobacco is the perfect example of what happens when you don't pay attention to underserved populations. It is one of the top 10 public health achievements of the last century. We have driven tobacco prevalence rates from about 45% to about 10%. And what we've done is concentrate it in historically marginalized populations, in underserved populations, in vulnerable populations, such as folks with substance abuse or mental health disorders. So it's the perfect example of where we can do good things on a population basis, but actually make health inequities immeasurably worse. The other thing that I see in our work, it started actually, we've been working in low SES populations for 25 years, was that they couldn't pay attention to the target behavior because they were worrying about how to pay the rent, how to keep the lights on. And so until we have the political will in this country to do something about the social determinants of health on a larger scale, which is obviously what we need to be doing, our work needs to at least think about how we can try to mitigate what's out there now. And treating people equally is not the answer. And I'm going to use an example from our own work. I told you we do a lot of intensive longitudinal data collection where we follow people throughout a behavior change attempt. And so everybody has access. Everybody gets exactly the same pharmacotherapy. Everybody gets exactly the same behavioral therapy. And what do you see? You see that if you have lower incomes, you're unemployed, lower education, uninsured, you do worse. I know you can't read the labels, but take my word for it. The top line showing lower abstinence rates is always the disadvantaged group. It doesn't matter. Every single study we do, any way we slice it, we always see this effect. So many of you have probably seen this cartoon, which I love. I've seen it with animals as well. So, and I'm a sports freak, so I love this cartoon because it's like, we can't just treat everybody equally. We need to give everybody the opportunity to see the game. So So now talking about doing hard things, we've been really, really fortunate. I came to the University of Utah and Huntsman Cancer Institute about a little over 5 years ago, and we've been able to just develop a phenomenal set of partnerships with our State Primary Care Association, or OUCH, which when I first heard it, I thought was slightly unfortunate, but I've realized now that people in Utah kind of dig it, so I kind of dig it now too. We work with lots of different divisions and departments from the State Department of Health. And then we work with 13 federally qualified health center systems. We call them community health centers in Utah. So you're going to hear me refer to CHCs or community health centers rather than FQHCs. So one of the things, why this is hard work, everybody's an independent entity. This is not like doing something with Kaiser. This is doing something with 13 independent healthcare systems that can do whatever the hell they want. They don't need to go along just because somebody else does, and they don't. So when you develop projects with this group of partners, you need to, it really makes you be deeply engaged, because you have to create projects that work for everybody. Work for the State Department of Health, the PCAs, the CHCs, et cetera. And how we kind of do that deep engagement is we always have, of course, what everybody and their dog has, patient and community advisory boards and things like that. But we actually have a weekly, it sounds crazy, 2-hour-long meeting every Friday that has about 20 to 25 attendees from all the partners, and we discuss all the projects, we address concerns, we get feedback, et cetera. The other thing I think that we've done that is rather unique in terms of engagement is this lovely lady in the red blazer is actually an employee of OUCH. Prior to COVID, she embedded 4 days a week with us on campus at the Center for Hope. We're only going in about 1 day a week now, but she comes in and engages with us on that day. And we jointly fund her through the Center of Hope, through OUCH, and through the Utah Department of Health. So everybody pitches in, and what it gives us, she worked for 10 years on the front lines in a CHC. Her desk is 20 feet away from mine. We can go get community feedback, hear the voice, hear what'll fly, what won't fly, boom, boom, boom. So the way we make these partnerships work is we really are focused on addressing what the community wants to do and how we can best do that. So that means that you've got to share goals. I started working, I've trained in addiction. I started working in tobacco. Now, I do HPV vaccination. I do colorectal cancer screening. I do COVID because that's what the community wants. And if I go in there and try to get them to do what I want, nothing good is going to happen. You've got to meet their priorities. And you've got to share resources. Academics, honestly, let's, I'll look ourselves in the mirror. We've historically been pretty dang stingy. And I get it because our budgets, are always, limited, we're always under-resourced, but you have to share the wealth with your partners. And so we listened to what they need, and they wanted a population health management tool that would help those 13 independent healthcare systems come together so that they could actually gain some benefit from, population health management approaches for reaching out on HPV vaccination, for example. So we've provided a ton of funding to be able to do that. We provide funding to the centers to actually implement health information technology. And then what you get out of that, though, is Utah Department of Health. We've got one of the big PCORI pragmatic trials statewide. They shifted a ton of their funding. So because now we were able to take care of some of the things they were trying to do, so they shifted some of their funding to pay for medications for folks in the CHCs because half of them are uninsured, and so they have no way of getting medications. So it's really, if you can really deeply engage, share goals and resources, really positive things happen. And then the payoff is, of course, you get to reach really underserved populations. And I work in Utah. I know what the stigma of Utah is, right? We all do. I had it when we were coming there. It's like when we were getting recruited, it's like, oh crap, is there any health equity populations in Utah? CHCs always always are phenomenal partners. In Utah, it's half Latino, almost 10% Native American, 2/3 under the poverty level, half uninsured, and a big proportion of patients are in rural areas. And rural, you're all in the Northwest. Rural in the Mountain West is not like rural in the rest of the country. Rural in the Mountain West means you got to go 150, 200 miles to get to a clinic. 97% of the landmass in Utah is rural or frontier, meaning there's nobody there, and you drive for the West Desert for hours and hours and hours, with nothing there. So we've got these really cool partnerships in Utah. We're working to build them out in the Mountain West, and the rest of the Mountain West is very similar. And the reason we're focusing on the Mountain West is Huntsman, our cancer center there, just changed our catchment area to try to serve these 5 Mountain West states, because we're the only comprehensive cancer center in that region. And so we felt like it was something we ought to be doing, as just frankly the right thing to do. And that reaches, again, really phenomenal set of partners for reaching underserved populations. Payoff is, I'm not going to go through these. We've been able to just get grant after grant after grant because we can show this deep level of engagement. And again, every single one of these projects, though, has been driven by our partners and what they wanted us to do. When we got there, they did want to do tobacco, so that was right in our wheelhouse. But then after that, it's been colorectal cancer screening. It's been opioids. The last 2 years, all we've done is COVID. That's all you can deal with on a CHC. Their lives are dramatically overturned by COVID. And I could tell you stories but I'll start crying if I do. I'm choking up even just thinking about it, the things they do to take care of their partners. So designing for sustainability, I know there's lots of good models for this and all, but frankly, our whole model is just say, okay, if we do this in the grant, what would happen when the grant goes away? And they tell us, oh, well, that'll go away too, or it won't go away. So we build around what they tell us. Well, when the grant goes away, we can still do that. Health information technology, digital health is a phenomenal way to do that. Once we make changes to their EHRs, we work with the national EHR vendors, we create new templates, things like that. Those things live on long after we're gone. So we do a lot of that as a basis for some of the foundational work. You have to, though, tailor those very specifically for underserved populations, underserved health resource settings. And what I mean by that is we have Epic at UHealth. You can do trapeze acts in Epic. Epic is freaking amazing. The EHRs that the CHCs have, there's no branching logic. You can't, if someone says they're a tobacco user, you can't pop something up. For Epic, you can pop something up and say, I want it to go for him and her, but not those 3. Literally provider by provider, clinic by clinic, provider type by provider type. You can't do that in community health centers. Their EHRs do not have that kind of functionality. So what you do has to be really specifically tailored. And it's not, it's a different world. It's just a different world. And I've been really lucky in that we have a world-class Department of Biomedical Informatics at Utah. And somehow they were telling us about their collaborations with Duke and Vanderbilt and how cool they were. And I said, I've got a challenge for you. And somehow these guys have it's 2 guys, so I can use that in a anyway. They have really got into health equity. They've totally got into it. They've totally that's what they want to do. Gives them purpose, gives them meaning. They want to do this kind of work to try to figure out how to make the best of sort of really limited, constrained kinds of technology approaches. We never try to reinvent the wheel. We use staff from Ouch. We use staff from community health centers. We're not trying to put things in place that are going to go away. So we're always working with them to figure out what we can do. We try not to build data reporting systems that are going to go away. So we're able to leverage with our work with Utah Department of Health, real-time data on COVID. They tell us actually in our COVID projects, go target this hotspot. Utah County, we'll throw them under the bus. They have been elevated for 3 months about double the state rate. Go there, get them some help. So we're really able to leverage that. And then we're not trying to create new interventions that are going to go away either. So we collaborate a lot with quit lines. Quit lines are phenomenal because they will treat you regardless of your ability to pay. And many of them across the country will actually provide pharmacotherapy regardless of your ability to pay for it as well. We use the DPP and whenever it's available online, lifestyle change programs. State gets funding from the CDC to do breast and cervical cancer. We get funding to do colorectal. So we leverage everything that's already there. We're not trying to create stuff that as soon as the grant goes away, it goes away too. And then my last real slide is sort of on mechanisms. And, trained as a clinical psychologist, we're all about one single person kind of a lot, that's what you really think about. So you really think about mechanisms deeply. And I think we need to kind of start getting to that place a little more in implementation science. And I'm throwing ourselves under the bus too, because we've not been doing it. So I'm not, on a lot of this stuff, I'm not claiming like we're not doing a lot of it either, but we need to be developing this kind of rigor in examining the mechanisms of why the strategies, the approaches that we use, whether they work or don't work. And then the last thing is I feel like we've worked with the community health centers enough now to know that the vast majority of things we ask them to do are frankly ridiculous. Ridiculous. They do not have the IT infrastructure. They do not have the IT expertise. Their EHRs lack the capability. They do not have the ability to utilize big data. And so the stuff we ask them to do is just nuts sometimes. And so I feel like we need to be developing strategies for dissemination that actually take into account the resources they have, the capacity they have. And with that, thank you very much.
Thanks, Dave. We'll turn it over to David Chambers, who's joining us on Zoom.
Sure. Can folks see me or hear me or both?
We can currently hear you. I think
Okay.
we're waiting for your video, maybe. There we go. Now we got you.
Oh, okay. Yes. Now I can see myself. I think I can see 4 of me or 5 of me, which is interesting. Okay, now 3. So sorry that I can't be there in person, but very appreciative again for technology being able to link us as best as possible. Maybe a favor, just because I'd love to see what it looks like there, both at the stage and in the audience. If anybody who has my email could just snap a couple pictures and send them to me, that will help me understanding context as you've all heard, as we've all said. As folks have said at SPR this year is incredibly important. And so knowing my context will be increasingly helpful as we move on to the discussion. Second thing I want to say is just following Shiriki and Dave means that I could just say ditto and then use the 14 minutes to play a couple songs or something like that, because I appreciate so much what they said and absolutely second most everything that I already learned from them. But I do want to maybe package some of this in a slightly different way and think a little bit historically, at least for me. And JD mentioned that SPR used to be a more frequent stop along my itinerary and hasn't had as much of an ability to be on that just due to a few competing demands. But so great to be with you all again. JD mentioned the 30th anniversary. For me, this is the 20th anniversary of the first time that I came to SPR. So I started at the NIMH in 2001, and I was brought to at least think through a more rigorous, I guess, portfolio around what was then dissemination research, became dissemination and implementation research. And the very next year, just from the advice of my colleagues at NIMH, at NIDA, at others, at other institutes, they said SPR is the place where so much of this is already happening. And I knew that the leaders then, 20 years ago at the Society for Prevention Research, were well ahead in recognizing the need for a knowledge base to support the implementation of our evidence-based interventions, and the recognition that that was a scientific endeavor and not just something that we muddle through by ourselves. One of the first talks I ever gave on this topic was at SPR 20 years ago, I believe in Seattle. So I wish that I was back with you again, a little more gray hair now, but hopefully a similar smile. And then right after that, we had established a first set of workshops at the NIMH to try and pull together the great work that was already going on in this field. We concentrated on child and adolescent mental health, dissemination and implementation research, and among the folks around the table were so many great investigators who have been a part of SPR. Just want to say that the standards of evidence that were created by the society over the years, thinking about standards for efficacy, for effectiveness, and into dissemination and implementation were really helpful for the field and certainly for those of us at the NIH. And one other note was that SPR also gave me this wonderful opportunity to entertain. So there was one of the SPR meetings in the DC area where the Mothers of Prevention band was unable to perform. And so we were able to fill in for them inadequately, we know, but it was very fun it was probably the only gig we did that had active dancing and impressive dancing at that. So anyway, so my gratitude, my love and affection for SPR continues, possibly unrequited, I don't know, but I very much appreciate all that I've learned from all of you. And so then when we think about the field, at least the field that I've been engaged in, D&I research or implementation science, so much certainly has been learned from what you've all done in the prevention science area, right? We know about the multi-component interventions and the challenges with trying to implement them. We know about multi-level interventions from all the great work that you've done, from individual on through society. And again, the challenges of trying to disseminate information about them and implement them. We know that there are multi-level approaches to implementation that are incredibly important, and that we know that our interventions will often have multiple targets, multiple outcomes, multiple roles that they need to play in people's lives. All of that comes really, I think prevention science is ahead of some areas in recognizing just the complex nature of the interaction between our interventions and the places in which they can be used and presumably benefited from. And so I personally learned so much from the leaders of Prosper, of Communities That Care, of the Nurse Family Partnership, of Incredible Years, and so many other interventions that really were those early efforts to move from, we've established in trials that these things work, now we need to make them as available for everybody as possible. Now, along those 20 years, D&I research has also progressed. There was a lot of early frustration because we had intervention developers, hopefully, some in the room among them, who were saying we have these great interventions and we're not getting them used to the extent that we would like to. And so we were moving from this conversation about why can't we implement things to can we get things implemented, and then increasingly to how do we do better with implementation. And that's a really helpful progression. In 2002, it was the first time that we had a specific dissemination and implementation research in mental health announcement for us at NIMH. And then we were fortunate to collaborate with so many great people a few years later to expand that across the agency. A few years later, 2007, we had our first conference on the science of dissemination and implementation. We're now in our 15th year. So it's been great to, again, have so many of you a core part of the programs that we develop each year. And then starting in 2009 with the Implementation Research Institute and other R25s like that, which Shiriki mentioned that we've both been engaged in over the last few years in chronic disease, we've seen a great explosion of opportunities for the field to collaborate, to connect, and to expand. So what's been exciting over that time? I think it's been exciting to see a shift from this idea that things are static, that we know exactly what's happening in our context and we know exactly what our interventions look like, and we can simply rest on our laurels by making that one-time fit. And really shifting to this recognition of the dynamism, and obviously well characterized by what we've all been experiencing, not just the last 3 years, but many years before that. It's been great to see a shift from this primary and at times sole focus on the fidelity of our interventions to thinking about how we integrate adaptation. It's been great to shift from this notion of we can simply rely on the communities and the systems that are willing to work with us and be satisfied to how do we focus on dissemination and implementation for all. And I think there's been a nice shift from this assumption that if we just create an opportunity for interventions to be delivered, that access is fine and people will follow. And now even more and more and more, overdue certainly, but a recognition of the social determinants of health, of the structural challenges that get in the way of that fit between what is demanded or requested and what we're able to supply. I'll say personally on the equity front, one of the lasting experiences that I had when I was at NIMH was being able to be part of this Community Partners in Care project, which Ken Wells at UCLA ran and Loretta Jones at the Healthy African American Families Foundation had pulled together. And I think what they recognized and what they taught me, among other things, was how important it is not to assume that a project is the bounds of our relationships, that it's about creating a long-term engagement with our families, with our communities, with our systems, if we ever want to build toward better access, better cost, better quality, and better outcomes of the programs that we're trying to deliver. They talked a lot about stone soup, about this idea that everybody has an ingredient to contribute, and out of all of those ingredients come the wonderful recipes, come the wonderful outcomes that we're all trying to achieve. They taught me, and I still, I hope you can see this, I think you can, they taught me about keys. And there was a meeting that we went to, I don't know if you can see this, it's a key that is not cut. But it's a meeting that I attended in Alexandria, Virginia, where they were talking about how everyone should take a look at the keys that are on their key ring. Recognize that each of these keys has a purpose, it opens certain doors, but not everybody has access to those keys, not everybody possesses them. And our challenge, and with that uncut key that I carry on my key ring to this day, it was a recognition that we should all be thinking about the next set of keys that we need to fashion. We should be thinking about what we can do to enhance equity. And those lessons have stayed with me and continue to sort of motivate me to do better. So where do we go from here? Well, there's clearly opportunities and there's clearly challenges that we have to overcome. There's far more, as the speakers before me have eloquently said, that we need to do to truly embrace equity. We need to move beyond the idea that for any given intervention, 100% uptake is always the goal, that there's a presumed fit between what we are designing, even if we try to design it well, and what people actually need. And so redefining what success is incredibly important. Just as redefining what are the questions that we need to ask and how do we ask them. And the wonderful partnerships that certainly Shiriki and Dave have been leading pieces of to make sure that we're reflecting those who use our interventions, those who deliver our interventions, those who have to support the receipt of our interventions. We need to make far more explicit assumptions about access, about quality, about engagement, and actually test those assumptions rather than saying we actually know the right next move. And we need to recognize that there is a need for continued development of infrastructure that supports not just D&I science, but D&I practice. And what are the constraints that we're continuing to add upon busy people with multiple competing demands within communities and within systems? We need to continue to go to where people are, and certainly the last few years have asked us to rethink where we deliver our interventions, where we receive them, and how we communicate. With communication, I think even more than ever before, we have that understanding that misinformation is the reality. And thus, in a conference on dissemination and implementation science, we can't just be thinking about the implementation of our interventions, but all of the various ramifications, the influences on the whole dissemination process, where it goes well and where we misfire. We've had a bunch of recent successes, which make me continually enthusiastic. So more and more of our funding agencies have recognized the importance of D&I science. It's been embedded in more strategic plans. Leadership certainly at many, many agencies, and you hear it within congressional hearings and funding announcements, are extolling the need for more dissemination and implementation science, which is a great thing. We've seen more research centers, funded infrastructure to try and create partnerships among community and clinical and public health settings, to think about how we can advance methods and measures, to do more innovative work, and ongoing data collection to make sure that we know what questions we should be asking and how can we answer them in the best way. We have seen continued work to expand our training programs, including the development of open access materials for everybody. So it should not be a barrier for people who are interested in doing more in this work to have to be a part of a single mentored course. We've seen more hires within research institutions, and us just speaking from NIH, has been so wonderful to see a bunch of special initiatives that really are in the spirit of or directly focusing on dissemination and implementation science. Things like RADx Up, which Dave had mentioned, the transformational health disparities initiatives, SEAL and HEAL that we've been able to see, whether it was around pain management or enhanced testing. And then as we move toward the future, there are areas that we need to shine more of a light on. As was said before, equity remains a work in progress, and it remains important not just to say this is lip service or this is a fad, but this is baked in to everything that we do. That we shift from this idea of the sort of fidelity versus adaptation to really think about the evolvability of our prevention programs. So how do they evolve over time? How do our settings evolve and the needs that they have, the evidence evolving over time? And then how do we continue to learn over time? We absolutely can't just keep putting more and more into our overstressed systems and communities. So how do we de-implement? How do we create room? And how do we recognize that there are some suboptimal efforts that are not doing justice for the people that they are trying to help? We absolutely, I think, need to do more. And again, this is an area where prevention science has been leading, of bundling multiple interventions together. And as Dave said, much more on mechanisms. And a shout out certainly to our colleagues in Seattle and elsewhere who've really been asking us to think far more about mechanisms, mechanistic studies in D&I. That's been great. So finally, just want to say thanks, everyone. I wish I could see you all, and hopefully at some point there will be an email that allows me to do just that. So I'm going to pass it over to JD and look forward to the discussion.
I don't know if we're able technologically to bring up our 3 people simultaneously who are online for our discussion. Otherwise, I guess we can cut to the folks who have hands raised, et cetera. So that was an incredible display of knowledge and years of experience. I can start off the questions, but I would love to have somebody from the audience kick us off if there's a burning question for any one of or all 3 of our panelists. All right, great. I get to ask a hard question then to start us off. So, clearly from the work that all 3 of our presenters talked about, they've been deeply embedded in dissemination implementation science, health equity, or both for quite a while, and certainly have probably a lot more to share than we were able to give them time for. I'd like to ask the question of, 10 years ago, what was something that each of the 3 of you either wrote or spoke about that we needed to achieve or needed to address in the next decade that really either hasn't been addressed and is going to be a critical challenge for the next decade, or maybe something on the positive side that you said, we really need to do this, and we have in the last decade? Kind of thinking ahead about what we might need to do in prevention implementation science for the next 10 years. So I don't know who wants to start. This was definitely a put you on the spot question, so.
Yeah, well, David said he'll start, right?
Sure, yeah, no, I'll start. Yeah, so just trying to think, okay, so 10 years puts us at 2012. I think around that time, there were several of us who were and I'll shout out to Russ Glasgow and Kurt Stenge, and then of course others who are helping us to rethink sustainability, right? So at the time, the notion was sustainability is about preserving the initial state for as long as possible. And so we played around with different visuals. One of them I think Russ referred to as the meat slide, because I had drawn different blobs with other blobs around them, and they kind of looked like steaks. But ultimately became this notion of sustainability from a dynamic perspective, and trying it, as I said a bit ago, trying to get away from this idea that we know everything and we simply just move forward and what will be, what we know, what's going to happen. And so, yeah, 2012, 2013 was the development of this dynamic sustainability framework. I know the field said we didn't really need another framework. Maybe we don't anymore. But nonetheless, it was a nice, we thought, way of trying to suggest that our work is never done, particularly if we care about sustainability. So I thought that the helpful thing was that we were at least trying to put words and trying to put visuals to this concept that seemed a bit elusive, at least for us, although recognize that others at SPR, by the way, thanks for sending me a few pictures. It's been nice to be able to look at that. But on the flip side of it, I think where we haven't necessarily gotten, even in the last 10 years, is as good operationalization of what that actually means. So we talked about, we need to be able to capture evidence over time. We need to be able to capture how our interventions are being delivered and how they're being adapted. We need to be able to capture the context. All of these things are very challenging and at times elusive from one intervention to the next. And so the half full glass is that I think we've had a lot of wonderful embrace of this idea that it's far more complex than we sometimes give credit for. But the empty side of it is to say that we can do better to try and say, how does that become feasible in our ongoing work, to be able to check back at how are we doing and how can we do better? So it's this fusion of sustainability with this notion of ongoing learning that 10 years ago, at least, was a promise. It's still a promise now, and hopefully we can get there.
Thanks, David. Dave or Shiriki?
I'll be happy to, but if she wants to go first, let her go.
No, David, you can go.
I guess we've got to defer to Dave.
Yeah, no, we're going in reverse
Okay.
order. No, okay.
Yep, I guess we're on you, Dave.
Sure.
Sure.
I remember reading an article in the American Journal of Public Health that has just recently been updated. But this is the original one was, gosh, I don't know, 10, 15, 20 years ago. And it said that if a primary care provider did everything they were supposed to do in the US Preventive Health Services Task Force guidelines, it would take them 7.5 hours a day. And they've not yet asked about the presenting problem. That's recently been updated to be 8.5 hours. David talked about de-implementation, but what it struck for us was we've got to get the hell out of point of care, right? You can't do everything in the point of care. That's a ridiculous sort of notion that we can do all those things. So that's actually kind of started us on thinking about trying to do more population health management approaches where you can reach out proactively to patients. You don't need to wait for them to come into a clinic. And frankly, that was because we were doing that, that was the saving grace during COVID, because we have 3 RADx Up projects. People didn't go to the clinics anymore. And so because we had this infrastructure built for population health management, we were able to reach out. There was to 110,000 patients in a matter of months. So that for me was sort of really, how do we do healthcare without having to do it all sitting in the doctor's office?
So more population health.
Yeah.
Great.
Okay, so I'll go next. How long ago did I have to have written this? At least 10 years, you said? I wrote something with colleagues in our group that's now the Council on Black Health, and we published it in 2007. So I think that qualifies. And it's called An Expanded Paradigm for Obesity Research. And the point of that article and the graphic that was associated with it was that if we were looking at that the reason we weren't succeeding in some of our interventions, especially this was focused on individually oriented interventions, was because we were looking at the people through the problem lens instead of looking at the problem through a people lens. And so we tried to make the point that, and I think it really comes through very clearly in something like obesity, where eating and physical activity, which are the final pathway for weight control, if you think about how fundamental those types of activities are to life, and then you look at people through this narrow lens of whether or not they're achieving energy balance, as if they get up in the morning to achieve energy balance, as opposed to whether the energy balance is a function of what they actually get up in the morning to do. So that paradigm is still with us as a basis for maybe understanding better what is underneath community engagement. So when we take our interventions to a community, that's one thing. But if we go to the community to see what they're doing and then see where our intervention fits into their lives, we might get a different perspective. So we had a Venn diagram with historical and social factors, with a big emphasis on historical factors. And then there was the psychosocial and collective experiences in the psychosocial realm. And then on the right-hand side were the physical economic environments like the food marketing system and so forth. So that's my contribution to this question.
Thanks, Shiriki. I have my co-chair online as well, Dr. Sandy Naoom from the CDC. Sandy, I don't know if you have a question ready, and if not, I'm happy to ask another one.
Sure. Can you hear me?
We can.
Yes.
Okay. So I don't, it's not a well-formulated question, but, a lot of things have kind of come up in listening in these last couple of days to a lot of the presentations at SPR. And so I think one of the things that's come up consistently is it doesn't really matter how effective our interventions are if we're implementing them in communities whose focus is really on basic social needs like food and housing. And so I guess just kind of got me thinking for a really long time, we were so focused on developing effective interventions. And then kind of we moved past this development of effective interventions and really kind of the field grew around thinking about what effective implementation looks like. And so I guess I'm thinking now kind of, in terms of what's next, kind of what does it mean to be looking kind of at effective? And I don't know that we should call it context, but really thinking about kind of how do we address these kind of structural challenges and how do we do that kind of in our, the way in which we kind of look at effective interventions and effective implementation. And so is this really just thinking about kind of how do we embed that within thinking about the stages of implementation? Is that really thinking about how do we better address or measure? We can be thinking about fit. I think I worked on a project where there was some concern from the funder that the implementers were so focused on supporting the social needs of their communities that they were unable to implement the intervention. And now I think, well, maybe they were kind of ahead of their time. And so anyways, I guess what I'm thinking about in terms of our presenters is kind of what advice would you have for kind of program developers when thinking about the design of their interventions to kind of integrate that kind of thinking, really to support the implementers kind of when they are faced with kind of this situation. They're in a community, they have an intervention that they think is effective. They even have really good strategies around how they'll implement them, but really they're faced with these basic social needs that need to be met within their community before they can even get to the point of implementing this intervention.
Yeah, I'm not sure who wants to jump in on that, but that certainly has been a pretty predominant theme here in the conference this week.
Let me comment on that because I have pretty strong feelings about that would probably get me kicked out of the room if I were there. I think that the whole concept of an intervention that's not contextualized is an invalid concept, and that we should move away from a definition of evidence is that it's something that's created outside of the context of people's lives, and then to realize that people's lives may not be as easy as those of the people who are developing the intervention. So that's one of the things that I just get stuck on in terms of implementation science, that we still understand evidence as something that's contrived in a certain way. And I was pleased to see that some of the colleagues who are leaders in this field, I think it's Ross Glasgow and Rachel Shelton, about changing the definition of evidence, really taking a look at how we're formulating that, because I don't think we'll ever get to equity if we don't do that. And then the funder would say, you're so busy doing meeting the needs that you can't do the intervention. They shouldn't be separate.
I was hoping we'd have some provocative responses, so that was we're getting there.
So happy just to add in and appreciate Shiriki's comments. I wish on some formats there's the little thing where you can applaud and you can express your appreciation for the comment. I was trying to find it, but all I have is the hand raise function, so that's not going to work. So I think it's a great question, and I think the other thing that at least a few years ago at the NCI we were thinking very narrowly about some of our existing interventions and their ability to be delivered through technology. And we had an opportunity to participate in this departmental sort of innovation. It was like there's I-Core, Innovation Core, and it was this kind of boot camp to help us think through, could this be the makings of an initiative? And the main thing that this I-Core program told us to do is get out of our own offices and start talking to the people that were, in this case, developing those interventions and see what are some of the challenges they're having or what are some of the needs that they see. They reported to us, and again, this is in the cancer control space, but might resonate with other folks, that many of the investigators who were developing these interventions had never actually gotten much training on how exactly to get out of their labs or how out of the teams or the local circumstances that they were sitting in, or were told you don't actually need to do that until later on in the scientific process. And so we were able to modify that kind of a program. It was called SPRINT, which was Speeding Research Tested Interventions, to try and help people think more as they're designing the interventions. And Ross and others have talked a lot about designing for dissemination, but really to think through who are the people who are trying to reach and what are their needs? Would they even use this intervention as it's currently developed? How might we need to modify it? And in many cases, even though they were in the midst of an R01, they thought to themselves, I might have designed this a little bit differently had I had more of an opportunity to really think about where this is going. And in some cases, they had the chance to redesign it. In other cases, they were thinking, even if it wasn't the typical sort of business model, they were thinking about what's the sort of broad marketplace and does this resonate? So that's sort of one piece. I do think that there are more folks helpfully in the implementation science space who are saying, how well are we doing to try and capture social determinants of health? How well are we measuring rather than just assuming we know exactly what basic social needs are potentially interacting with the programs that we're trying to develop? And so, I think it is related, Sandy, to your point about, what is it that we measure? What is it that we design? What is it that we integrate? And just to sort of second Shiriki's comment that if we're not thinking about context, then it's very rare that we can create an intervention that's actually going to be as useful as we think it is.
If I understood the question correctly, and I'm not sure I did, but we feel like this is something we've faced for 25 years, and we would be trying to do motivational interviewing with tobacco users, and I actually mentioned it a little bit in my talk, and they'd be going, I can't focus on quitting tobacco use. I can't pay the rent. And so we developed this thing that we call motivation and problem solving, where we stole the good pieces of all sorts of different intervention approaches, but it was built around a wellness plan where we actually identify all the person's concerns, et cetera. And then we actually became the social needs connectors, the actual interventionists. And so that that sort of just happened not because we had any grand plan, but because our patients were telling us, here's problems I need to deal with before I can actually deal with your target behavior, because that's not their target behavior. And then the other thing, out of our M Health work, I appreciate the comments because, one of the things we say about low SES tobacco, I say about your low SES tobacco use, it's a miracle they can quit. We've done with our M Health work where we look at social context, and we look at whether their cigarette smoking is allowed in their settings, whether they're around other smokers, whether cigarettes are available. And it is overwhelming. It's all over the place. And if you know anything about drug addiction and you know anything about cue reactivity, there's a great review that just came out. Your brain lights up when you see a drug cue. And so we need to not be just this individual level kind of intervention ain't going to cut it. No matter what we do, low SES folks are going to have more difficult time quitting until we are able to sort of change this whole social world, whether that's through social norms change, whether that's through obviously smoke-free laws, whether we, ever get to tobacco end game, et cetera. So I completely agree. And we can try to contextualize interventions, but we've really got to think much more broadly, I think, than we used to on a lot of that.
I put my hand up, JD. Can you see that?
I can hear you. You're good.
Okay. I think that it would be useful to study what it is that the people who do benefit from the intervention had to do to make it work. Because I've always thought that the reason that the interventions look like they're working in other people is that the participants are helping you. They're helping you by rearranging their schedules or using their job latitude or finding other methods of stress reduction. Because just in general, if the behavior is embedded in a context, then somebody's managing that context for the intervention to work. And so that's another way to look at it, which might give some insights, and to be able to go back and tell funders, it's the reason we have to work on social needs is because the participants can't do it for us, or to look at the intervention and document all the things. We think about the interventions in childhood where, or 10 weekly sessions, and people have to get to those sessions. I think it's showing up that it's easier with virtual, because that's a major lift for a lot of people. And you have to be able to handle that. So, that's another way of thinking about it.
Yeah, that's a really interesting way of thinking about it. Really thought-provoking. I don't have access to the Zoom, but I did see there was a question in the chat. Sandy, do you want to take the question from the chat since you have access to it?
Yeah. So the question or comment is that earlier in the conference, sorry, I'm trying to read it and move it at the same time. Earlier in the conference, Dr. Murray brought up the importance of understanding what we define as a problem for community versus what community residents see as the issues they're facing. Oftentimes, these are not the same. How do we identify or consider spaces where evidence-based programs are not what is necessarily needed for the community? How do we enter these contexts with humility and with an understanding that we may not have the evidence that is needed to address the particular community's concerns, focusing on what the community defines as the problem, not what we define as the problem?
Yeah, good question. I mean, I'm going to tap Dave to start with this one since you talked a little bit about it.
Well, I'm like the simplest guy on the planet, as JD knows. You just ask them. I mean, literally, we've gone in. I'm going to tell a story. Went into Legacy FQHC in Houston. I was at the University of Texas MD Anderson Cancer Center for a long time. We met with all the medical directors, and they said, "Okay, what do you want us to tell us about?" And we said, "Oh, we don't want to tell you about anything. We wanted to ask you what your big problems and priorities are, and see if there's anything that might be something we could work on together." And one of the medical directors, "Oh my God, this is just like Christmas." And so that's, I mean, for me, I don't, I know there's all these really fancy models, but I mean, I think it goes back to Shiriki said. You go in with humility and you ask them what their problems and priorities are. And then don't implement what's in your head as the solution. Work with them on what's the real solution. So I don't know. Very simplistic answer, but.
Yeah, and I'm going to save our other respondents from having to talk the whole time and do one of my own responses. Chair's prerogative. So one of the things that has happened a couple of times with our community partners is, really an approach that starts with that openness, that humility, usually with some kind of an idea in mind. Since I'm not an expert in, everything out there, I clearly cannot lead a grant in everything. But we approached a couple of different groups at different times for projects, and sometimes we were able to do something with them initially, but the long term of having these really good relationships is that those partners then eventually come back to us to address those issues. It isn't even, the door is automatically open when you have that relationship to where I don't have to go formally have a meeting. One example, we work with a community health center practice-based research network in Chicago, and they knew that I was really interested and had a couple grants in pediatric obesity. And we had talked with them, we had submitted a grant that didn't get funded. And then they got a community needs health assessment back that said one of the biggest issues that was diagnosed was pediatric hypertension. So the PI or the director of research reached out to me and said, hey, would you want to go in on a pediatric hypertension grant? I was like, what's pediatric hypertension? And we were able to get, an NHLBI grant for pediatric hypertension, and that led into an adult hypertension grant as well, based on the work that we had done with them. So some of these things do tend to, being a good partner, having that long-lasting relationship tends to go both ways. And so that's another piece for that, listening to the community and being responsive to what they need can be really helpful.
We had the exact same experience with opioids. They said, we need help with opioid use. And it said, we know nothing about opioids, but we'll go find somebody. And we went and found somebody that we trusted to actually work with the community, because you have to be real careful about who you bring into those partnerships too, because, you can screw those up really easily. But that's the exact same thing. So we went and found the opioid researcher, and we've got an opioid grant.
And Dave walks the walk. He won't let me talk to any of his community partners. So.
Not true. Not true.
So maybe one other thing, just reflecting back on conversations I've heard at SPR over the years. I mean, I think the idea that we too often have the specific evidence-based intervention that we're trying to say this is the solution for whatever your problem is. But in SPR, there's certainly been this legacy of these broader community level or sort of system level decision support systems, right? With the idea that the first thing that we need to do is to be able to assess community needs or school needs or family needs before we start saying this is the evidence-based intervention. I love the idea that often those conversations may move to a totally different domain than what one was most qualified to talk about. But it seemed like, again, just looking back at the great work that folks in the room and elsewhere have done, that this idea of decision support rather than solution that we will simply be able to turn over seems like it's worked pretty well.
Any questions from the audience? Don't be shy. I know it's like right up here and everything, but if anyone has a question or a comment. And if everyone's totally tired and ready to go to lunch, we could probably do that as well. There will be an opportunity to continue the discussion with our panelists. We have the plenary roundtable will happen after lunch. I don't remember the room, but we'll be there having a pretty informal conversation about these issues. And frankly, this is your captive audience for all three of these folks. So if you have something that goes beyond the topic of the plenary for David or Dave or Shiriki, certainly I'm sure everyone would be happy to talk. So let's break. And thank you all again for coming to this session of Friday. Thanks to our presenters.